Hi there, my name is Kirsty and I am here to tell you a bit about how to manage post-tonsillectomy hemorrhage. So the talk will aim to cover referral for tonsillectomy, categories of post-tonsillectomy hemorrhage, and later how to manage it. And to do this, I will use a case to form the basis of the talk. So we have a 19-year-old female who has attended A&E, bleeding from her mouth. She had a tonsillectomy 18 hours ago. She said the operation went well and is otherwise feeling fine. She has no allergies and her past medical history includes otoplasty and recurrent tonsillitis. She takes no regular medication and this has never happened before. She believes it is secondary to her tonsillectomy, which happened recently. She is currently not actively bleeding in front of you. However, about an hour ago, she documented about a tablespoon of blood coming from her mouth. So why do we think this lady got a tonsillectomy in the first place? Well, I think it's quite clear from her history that she has had recurrent tonsillitis over a recent period of time, and the sign guidelines, as shown on the screen here, suggest that recurrent tonsillitis the episodes have to have occurred within a certain length of time with a certain frequency. So, for example, 5 or more episodes of acute tonsillitis have to be documented well within 2 consecutive years, or for this lady, it was 7 or more episodes of acute tonsillitis within a year as being documented by the GP. There are some other guidelines which you can see if you just head to the sign guidelines for it. So, although this was the primary cause for her referral, there are a few other reasons why someone might get tonsillectomy and are therefore important to raise here, and I've shown them on the screen. So this can include asymmetrical tonsils, suspicion of malignancy with query primary SCC of the tonsils, treatment of malignancy as part of surgical resection, or sleep disordered breathing in children under the age of 16. And I put an asterisk here just to remind us that sleep disordered breathing must be confirmed using sleep studies and polysomnogram. Anyway, so why do we think she was taken to ED in the first place? Well, the most important red flag to be taken from her history is bleeding from the oral cavity. Any patient with such should be treated similarly with diversion to ED, irrespective of whether they've had a tonsillectomy recently or not, as spontaneous tonsillar hemorrhage is treated just as urgently. So next up, you decide to examine the patient's throat for fresh bleeding. It is normal for the operative site to look quite yellow and white and sloughy after the operation. As you can see, there is some evidence of that here in her mouth. But what's also important is that you're able to localise an area of bleeding or actually actively see some bleeding. And as you can see here, there is some active bleeding on the tonsillar bed. Now that you've confirmed tonsillar bleeding, the question is what to do now. What do I do as a junior doctor? And the two really important things are ABCDE, let's make sure this patient's stable, and call the ENT registrar, as they're the ones that are actively going to help with the tonsillar bleeding. It's really important that we take this presentation really seriously because this is an acute situation, and if not managed appropriately, patients can sadly pass away due to airway obstruction or hypovolemic shock. So it's really important that we take these necessary steps and do our ABCDE and call the ENT reg. So the ENT reg is now on their way and they ask you how long ago the tonsillectomy was. Why do we think that is? Well, there are 2 different categories of post-tonsillectomy bleeding. Bleeding within 24 hours is classified as primary, and anything beyond 24 hours is considered secondary. Knowing the classification doesn't influence the management strategy deployed. However, it could tell us as doctors whether the source of bleeding is likely as a result of surgical technique, commonly primary hemorrhage, or environmental stimulus affecting wound healing, which would be your secondary post-tonsillectomy hemorrhage classification. Now the ENT registrar asks you to find the surgical notes for the patient's surgery and asks if you know what technique was used. As you can see here, there are a variety of surgical techniques that may be used for tonsillectomy. They're usually differentiated into cold and hot methods. but your cold are really just cold steel with ties, cold steel monopolar, cold steel with bipolar, and then you've got your hot methods below, so monopolar diathermy, as you can see on the screen, and coblation as well is important to note. It was discovered that the patient underwent tonsillectomy using cold dissection with bipolar diathermy, which is actually the most common technique used in the UK. But why is this relevant? So I've taken this information from the Royal College of Surgeons England audit in 2004, which actually identified a connection between the methods that we use in surgery for tonsillectomy and the risks of hemorrhage afterward. And as you can see, your cold methods, as this lady does have a lower rate of post tonsillectomy hemorrhage in comparison to your hot methods and coblation. It's just nice to identify that and know that if you're ever in surgery and seeing this, there could be an increased risk for your patient afterwards. Now, what tasks might the ENT registrar ask you to do whilst you wait on their arrival to ED? There's a whole load of things that they'll probably ask you to do, and I've popped them here for you. So you've got IV access, bloods, remember suction if they need it because there is a risk of airway obstruction, IV tranexamic acid, antibiotics as guided by your ENT registrar, hydrogen peroxide gargles. They'll probably ask you to keep the patient nil by mouth as there's a risk of them going into theatre, and some analgesia as well. Please remember that. And I've noted at the bottom, blood transfusions might be appropriate depending on if the patient is hemodynamically unstable. There are a few other things that they might ask you to do. So call theatre, call in an anaesthetist, and CPOD for your emergency surgery. Just to kind of finish it up, I thought I'd add in a reminder of how to fluid resuscitate following the NICE guidelines. They are different for children and adults, so keep this in mind if you're ever presented with this. Obviously, if they're a child, you're going to do your 20 mils per kilogram of saline less than 10 minutes for your fluid resuscitation. For adults, it's 500 mils bolus over 15 minutes. But that's us. That's post tonsillectomy hemorrhage. If you have any other questions, you know where to reach us. Just go to our website for any more information. And as always, the rest of our teaching series can be found there as well. So thank you.